Okay, so hello, everyone. Welcome to my weekly show. My name is Lucy McBride. I'm a primary care doctor in Washington, D.C., believer of helping patients make better sense of their bodies and minds. And there's no more suitable guest than the one I have today for this show, Dr. Mary Claire Haver. Mary Claire Haver is the OG, the menopause queen. She is a board-certified OBGYN in Galveston, Texas, who I found during the pandemic dispensing fact-based, nuanced information about women's health. And I was like, I will have what she's having. So I started following her, and I've watched you, Mary Claire, now become this mega celebrity, if you will, best-selling book called The New Menopause. I think it was like 35 weeks on the New York Times bestseller list.
Yeah.
About, not that we're counting. And I think what it shows is that you are striking a chord. People are desperate for fact-based information about their bodies. Women have been deprived of information about their hormonal health, their metabolic health for so long. And so I'm thrilled to have you here. Thank you so much for joining me on the show.
So happy to be here.
So let's talk about why this is this moment. There's this menopause, like, mega moment where people are talking about it, and not a day goes by in my primary care practice where people don't come to me asking about what they've heard from your Substack, from your Instagram, from your book, where people aren't listening to Rachel Rubin or they're talking to their own doctors. Why now?
Interesting. I think social media has become a place where women tell their stories. And I learned so much about the menopause experience from women sharing their symptoms on social. And then I started digging. I mean, everything I've learned was really guided by the female experience that I picked up on social, combined with this, the Gen X, the kind of people who are in it right now are not willing to suffer. They're like, whoa, oh no, I'm not doing this. I am not going to quietly suffer through my vagina disintegrating, my bones disintegrating, my brain disintegrating. And I want to know what I can do about it, because this sandwich generation is no joke. And watching our parents age, watching our grandparents age, watching aunts and uncles age, my patients, when they come to me, are very, very focused on, once we put out the menopause fire and they feel like they've got their resilience back, they can handle it. But what if she's not that symptomatic? She actually feels fine, They are coming to me for the health span talk, okay, I've run the gauntlet of menopause. Here we are. My mom had dementia. My mom fell and broke her hip. My mom had chronic back pain from vertebral fractures. My mom had, whatever disease process that took her down, that disrupted her quality of life for an extended period of time. Because our fathers kind of, in general, certainly not all, and anyone's father who's dealt with chronic illness, God bless you. But, your mom's there to take care of him. And if she's not, you're taking care of him. And when she goes out, you're taking care of her. And so these are my patients who are like, help me figure out a plan that I can stick to that will keep this from happening to my daughter.
Right.
Because I don't want to burden my children with a protracted illness that somehow that I could work on right now and lessen that course of disability.
I think you're right. I think people are getting the memo that health is not just about quantity of life, it's about quality of life.
None of my patients want to live longer. Not one.
Right. I mean, I don't know about you, but my patients, I've felt a palpable switch in mindset. Maybe not a switch, but sort of like a couple clicks over from the mindset pre-pandemic. I think the pandemic had a major impact on people's lives and sort of conceptualizing health in perhaps a more nuanced way. At least I hope so. That's what I write about. That's what I talk about. Health isn't just about living longer. Of course, that is our job, right? To help people live longer. It's also to help people live better. And quality of life matters. The problem, obviously, with so many menopausal symptoms is that you can't measure them in a blood test. I mean, you can check hormone levels, but you cannot measure in a CAT scan and an MRI the despair that people feel because of their low libido and their absent sex life, the exhaustion of having hot flashes and night sweats, the instability of mood. I mean, that you just can't measure it in a blood test. And I think our healthcare system is so geared towards measurable outcomes. And, if you can't measure it, it doesn't exist. That I think women have been deprived for so long. Like when I was in medical school, I think we're about the same vintage, Mary Claire, that, I was taught in Boston in the 90s and 2000s to give women HRT only if they're miserable and suffering and give them for the smallest dose for the least amount of time. And that was not right. So I think that, and I was also taught in medical school to give people the most oxycodone pain medicines and use that sort of pain scale, right? So I think doctors need to be humble about what we didn't learn in medical school and training. And I've had to learn this on my own. Like I've learned
Yeah,
it through you. I've learned it through Sharon Malone. I've learned it through Kelly Casperton. I've learned it through Rachel Rubin. I've learned it through my own, just reading the literature. But I certainly didn't learn this in medical school. Is that fair to you? I mean, is that true for you too in
yeah.
OBGYN residency?
Yeah, I had, you know, the so medical school 1 hour, and it was just the most briefest, menopause is the end of the periods, and she might have a hot flash, but just pat her on the back, she'll be fine. Then I went into women's health, which really I don't think OBGYN is women's health. I think OBGYN is obstetrics and gynecology. And somehow we've decided that we have to shepherd all things and women, but really OBGYN is bikini medicine, breast, uterus, vagina,
Oh my
like
God, I have not heard that before. Bikini medicine. Yep.
it's bikini medicine as it should be, right?
Yeah.
Because why aren't internists all over this? Why isn't family medicine, any clinician that touches a female, 100% of us who live long enough will go through this biologically disruptive transition that will change the trajectory of our health for the rest of our lives. And what did I learn? Hot flashes, dry vaginas, and her bones will get weak, but there's really nothing we can do about that until she has osteoporosis. Then we're going to put her on all these anti-resorptive medications, which are going to tear her stomach up and be really hard to take and have very low compliance. And it's like, no one talked to me. When you look at prevention of osteoporotic fracture, it is roll up the rugs, grandma. It is not get in the gym, lift some weights, eat some protein. The anticipatory guidance around how women age is, well, what's happened? Look at the gender health gap. Women spend 25% of their lives in poorer health than men. Half of that time is after menopause. The other half is endometriosis, chronic pelvic pain, diseases that autoimmune diseases that primarily affect women. But say you get through that, now we're 3 times more likely to end up with Alzheimer's, not just because we live longer. We are twice as likely to fracture our hips, and have chronic pain and disability from osteoporotic fractures. And we're also more likely, on top of like more likely to be bankrupt, more likely to have low access to services. And then mental health, our mental health deteriorates. We have a 40% increase in anxiety and depression across the menopause transition. SSRI use doubles at 40 and goes up another 5% at 60. What? I'm not okay with this.
Right. Right. We've medicalized, um, menopause, which again happens to 50% of the population, women, if you live long enough. And as you have said, as I talk to my patients and say, like estrogen touches every part of our body, right? Estrogen affects our mental health, it affects our bone health, it affects our cognitive health, our cardiovascular health, our reproductive health, our vaginal health, our sexual health. So, you know, it is bizarre to me and not shocking that we spend so much time and energy talking about, men's health, erectile function, testosterone. Men don't blink an eye or bat an eye when talking about the risks of Viagra or testosterone supplementation. But we have the amount of scrutiny that hormone therapy has undergone is out of proportion to its safety.
Yeah, to the actual risk, which is for most women not risky. And like it is perpetuated. Yeah, so in my residency, we were taught to like treat menopause in a silo, right? You treated hot flashes. When her vagina got dry, you gave her some vaginal estrogen. When her bones deteriorated, you gave her bisphosphonate. You didn't give her estrogen. And so we knew, and that was about it. Like it was a very isolated, these are the things that we treat and nothing else. There wasn't a lot of discussion around cardiovascular protection. I remember one lecture where a guest lecturer came, was talking about the observational studies on estrogen and endothelial health, like decreasing the rate of plaque, so we knew this, right? That women who are on HRT tend to have heart attacks later in life, right? And delay the aging related onset of atherosclerotic disease. And then that's what the WHI was to prove that, right? Is it just that women on HRT are healthier and wealthier and, or is this an artifact of that, or is it really the medication? So what do we do in medicine? Randomized controlled study. So that's what the WHI was for. That 2002 was when the initial results were released with all the
Right.
fanfare and the drama and it went viral before things were really viral. And that was my chief resident year. So at that
Oh,
point, like I was graduating and like as I walked out the door, like don't let it because it was June, right? And I was finishing up end of June. The door hit me in the ass like don't give hormone therapy anymore unless. Like we need to give we need to give antidepressants. They might stop a few hot flashes, wait till her bones are broken before, or deteriorated before we do, any intervention. And I just bought into that because,
right,
I was busy. I
right.
was a good girl. I did what I was told. I followed guidelines. And I did that for about 20 years
Yeah, same,
until
same. I mean, HRT was thought to be causal of breast cancer. I mean, that was the mantra that if you had a family history of breast cancer or you were worried about breast cancer, you shouldn't be an HRT. That was the
right,
sort of that was the mantra. And it turns out that the Women's Health Initiative, that study was monumental. It gave us so much important data. It's not that that study was flawed. It's that the interpretation of it was flawed and scared the pants off of generations of women when in actuality, if I'm not mistaken, that the women who had estrogen only actually had
only at
reduced
30, yeah, 20-30%
reduced
reduced
risk for breast
relative
cancer.
risk
Relative
of
risk.
breast cancer. Yeah. So it was actually estrogen alone. So it was most likely the synthetic progestin that had, and it didn't even reach statistical significance. It was a trend towards a higher breast cancer risk. And
That's right.
and the placebo arm in that was artificially low. It wasn't like the population. So there's so many problems and red flags. All of this got articles written about it over the ensuing 23 years, but none of that got like no guidelines changed. No, until the Menopause Society, which is a rogue organization, is not part of the American College of OB/GYN. I did not know Menopause Society existed until 3 years ago, 4 years ago, when I started on this journey. I'm like, oh, what is this? ACOG doesn't recognize them. So they rewrote the guidelines in 2022. Amazing. ACOG has not updated their guidelines. It doesn't match. So if you're an OBGYN and if you're also a member of the Menopause Society, we have two separate sets of guidelines treating the same thing, so there's so much conflict, the messages isn't clear. And of course the doctors are struggling, and it's easier just to not do it than worry about the risk of you being sued or a patient getting breast cancer when she's
Well,
actually not going to get it.
let's also acknowledge that most people, if they're lucky enough to have a primary care doctor, I'm a primary care doctor. If they're lucky enough to have a primary care doctor, which 100 million Americans don't have, you may get 5 or 10 minutes. If you're lucky enough to have a gynecologist like you, Mary Claire, you may have a few minutes. There's not much time to talk about HRT, not to mention to undo a negative narrative. The negative narrative, undoing the narrative that HRT causes
That's
breast cancer,
30-minute
it takes
conversation.
a lot of trust, it takes a lot of rapport with your patient, it takes a lot of time, and it takes maybe multiple visits. Doctors don't have time for that. So I definitely remember 10 years ago, thinking that, wait a minute, HRT is safe. But if a woman came in and said, you know what, my grandmother had breast cancer, my mother had breast cancer, I'm not taking it, man, that made my job a lot easier than having to explain the data, which they weren't maybe going to believe anyway, when the press is still going bonkers with the messaging that HRT causes breast cancer. So I think the deck was stacked, or the cards were, however you say it, against women from the get-go. I think women are accustomed to suffering. Like, we do that well. We do suffering well, right? We quietly suffer and don't complain really well. So I think for many, many reasons, we were deprived of this information. I feel particularly bad for women who are in their 60s, 70s, and beyond now, who perhaps are listening to this talk, are looking at your book, reading your book, hearing the new message of empowerment towards women who didn't get HRT. Can we talk about those women for a second? these are my patients who come in with UTIs, they have osteoporosis. I try to remind them that A, vaginal estrogen is still safe in the standard of care for the genitourinary syndrome of menopause. And B, all is not lost. HRT is a wonderful thing, and it is the standard of care if you're in that 10-year window from your last period, but it's not a panacea, and you can still do things to protect
Yeah.
your bones, your
Yeah.
brain, and your heart.
Menopause care is a toolkit. And I say this all the time. And there are people who have an absolute contraindication or just don't want to take it. That's
Right.
fine. As long as, you're making that decision based on facts and not fear, my job is to bring the fear level down and let you make your own decision. Because I think that women, when armed with good information, will make great decisions for themselves. So, but, it's like, everything's a toolkit and fits together and works synergistically. So when one gets taken away from nature or a decision that you decide not to do this, you have to work harder at the other spokes of the wheel of health, which is nutrition, movement, stress reduction, boundaries, relationships, sleep. All of that is so critically important. Just slapping an HRT patch on to stop a few hot flashes when you're not taking care of those other parts are likely not going to improve your longevity very much or
Right.
your health
Right.
span.
Shout out, though, to vaginal estrogen. I was on
Oh,
Rachel
I think
Rubin.
it should be in the water. It's over the counter in certain countries.
Yep.
I think everyone should be on it. I think it's preventative.
Yeah, I
I
mean,
wouldn't want to wait until someone's atrophic or has, the cow's out the barn. Like, why would we wait? So
right.
I'm prescribing vaginal estrogen pretty much for everyone. There's no
So
reason. It's so safe.
it's so safe. Rachel Rubin was on last week. She's a dear friend, and she's like the vagina whisperer, and
Mhm.
she was talking about how to prescribe or how to prescribe and then how to take vaginal estrogen. What is your, I mean, just generally, what is your general guidelines for women? Do you recommend the cream? Do you recommend the tablet for? And we're
For
talking about from,
cost,
yeah, go
yeah.
ahead.
So for cost, the cream tends to be on the least expensive side. It's fairly well tolerated. Not everybody, it can get messy and whatever. It's alcohol based. For someone with severe atrophy, sometimes the base can actually irritate the skin. So we have to switch to like Imvexi, which is the ovule non-alcohol based. Sometimes we have to compound it, depending on what kind of skin irritation she may have. But in general, we start with a vaginal cream, and the instructions are 1 to 2 grams, 1 to 3 times a week. So it really kind of depends on if we're going in for prevention. Like she's kind of early in the game, but she wants to never get a UTI, never have dryness, wants to maintain the integrity of her general urinary system, and everything is. She has no symptoms. I would say once a week, would be enough to start. They come, the cream comes with applicators, but I tell the patients, experiment with the applicator, but they are hard to clean and multiple uses. And so I'm just like, put it on your finger and get up there with it. And then make sure you put some at the clitoris, at the urethra, and down the sides of the labia minora as well.
Yeah, the whole kit and caboodle, right? Rachel Rubin did a whole demo last week of just, I mean, I don't want to say you can't
The
overdose on vaginal
vestibule,
estrogen. What's that?
the vestibule.
The vestibule. Yeah. Just use your finger and get it up there inside and around the outside. And that should help you prevent UTIs, prevent some of the pelvic floor dysfunction. It's not a perfect thing. It's not anti-gravity. And also it can help with libido. So what about, so someone's asking here about, let's talk about estrogen, prescribing estrogen to women. What formulations do you like? Can someone who on this chat here has a factor V Leiden mutation, which can predispose you to blood clots,
Mhm.
take estrogen? What are the contraindications, the absolute contraindications, and how do you prescribe it? What are the practical
Okay,
methods here?
so when we talk about systemic estrogen therapy, so I'm trying to get into your bloodstream,
Yep.
right? So that it can go everywhere, all the cells in your body. It tends to not penetrate the genital urinary system very well that way. So we like to give it in the vagina, as well. But if we're just talking systemic, so we have oral and non-oral forms. So the two main categories, okay? They both get into the blood supply very well. And for the oral, that's a pill, okay? For non-oral, Lord, we have sublingual, we have troches, we have patches, we have gels, we have creams, we have a vaginal ring that's a high enough strength to go through. So it's like a 2-for-1. um, for systemic, and there's also injections, which are not FDA approved, so I don't use those. And there's also this subcutaneous pellets, again, not FDA approved, and there's other problems with the pellets we can get into later. So when we look at the differences between oral and non-oral, anything we ingest orally, food, medication, vitamins, anything, goes to the liver for processing first. So we have that portal vein. There's a hepatic vein that grabs everything up from the gut as it's being processed through, the small and large intestine. And then that venous system whisks it up through the portal vein into the liver for processing. When that bump of estrogen hits the liver, we see a very slight increase in our clotting factors. So about 7 out of 10,000 women, so very small amount, will have a blood clot on oral estrogen. Now, this was from the birth control data, which is a maxi dose compared to the mini dose that we use for menopause hormone therapy. So it's really hard to say, is it 7 or is it less? So it's no more than 7, okay, out of 10,000. But if you have a high risk for a clotting condition, your factor V Leiden, your whatever, just do a non-oral formulation. We remove that 7 out of 10,000 risk completely by switching away from oral and avoiding the liver on the first pass. And so that would be, so in our clinic, we tend to move, choose the transdermal options, usually the patches because of cost. Patches are generic and they are cheap, and we have 5 strengths to figure out what it's going to take for you. Now, again, one size does not fit all. I love having options. We have the spray, we have the gel that's FDA approved. We have samples of that in the clinic. So that's usually, the drug reps know what they're doing. And
Yeah.
so
Patients
I'll
love the
hand the
patient.
patient samples, see how she does, with the absorption of that, if she can tolerate it. No generics for those tend to be on the more expensive side.
Patients and patients tend to love the fem ring because the fem ring is that
Mm,
it's a ring that goes intravaginally and it lasts for 90 days. The problem is the cost.
cost.
Like, it's ridiculously expensive. And then
$600.
I found personally, but I found through patients that even though it's supposed to last 90 days and give you systemic levels of estrogen for 90 straight days, that the symptoms, or
We'll pick up.
the efficacy drops at, like, 75 days, like, sooner than 90 days. So I'm actually prescribing more and more patches. I find the patches are great. They're cheap. You have to change it out every 3.5 days or 3 to 4 days, and then some people are allergic to the adhesive, but it's pretty easy, I find. I mean, if you don't mind sharing, what is the starting dose for the average woman? Or does it depend on the person and their symptoms for you?
It depends on the person and their symptoms. There's newer data coming out about bone protection.
Mm,
So there's a little nuance around, does she have osteopenia? Does she have osteoporosis? Are we trying to build bone? Right. Um, so, the old data said, because we're only titrating the hot flashes, right? And any amount of estrogen will help your bones. True. But there is a threshold, it looks like, when you look at the data, that certain levels stop the degradation of bone that is menopause associated from the loss of estrogen. So you give her back X amount, and I don't want to throw out numbers here. Your doctors need to go look up those numbers from the Keeps trial, like everybody else. But then there's also a second level where women will actually build bone. You'll go back so you have a neutralizing effect and then you have a building effect. And so what are our nuances? Not everybody can tolerate the higher doses, breast tenderness, vaginal bleeding. So it really is not a one size fits all. What are we trying to treat? What are her treatment goals? You
right,
know,
right. So,
and
okay, so that's estrogen. Estrogen comes in the form of a pill. I don't
mhm.
tend to use the pill as much for the clotting risk
Tiny
reason.
bit. Tiny bit
Um,
for, it's the cheapest, it's really inexpensive,
yeah.
and the oral forms are what we have the cardiovascular data on, and so it looks like oral's a little bit better for protecting the endothelium and for lowering LDL because of it's kind of a double-edged sword. You get a lower LDL because you're hitting that liver first, and you're getting all the goodness of estrogen with the slight increase. So if someone's not high risk for blood clots, they're average risk, they are healthy, they're normal, low dose oral estrogen is probably really safe. I have a few patients who have maxed out on the patch, but they're poor absorbers. So they're getting the patch is great for mental health because you get that steady state, the FSH levels drop, your neurotransmitters kind of calm down, but they're not getting high enough, levels for bone protection. So we may add a pinch of oral or try to double up on their patches.
Yeah. It's interesting. I learned last week from Rachel that the transdermal delivery of estrogen is better for libido than oral estrogen. I did not know that. That's fascinating. I mean, these are the
Right.
things that, like, I'm still learning. Like,
Transdermal is better for brain.
transdermal better for
And
brain.
libido is a mood.
And
So
yes, yes. I mean, the biggest sex organ is your head, right? So that's estrogen. It's either oral, it's transdermal, meaning like patch, ring, gel, spray, and then progesterone. So let's talk about progesterone. If you have a uterus, it's funny. Sometimes I'll ask patients, "Do you have a uterus?" And they're like, "I think so." And then we have this funny conversation where it's like, "So no one's taken away." So if you have a uterus, you have to take progesterone in addition to the estrogen, right? Because unopposed estrogen runs the risk of overgrowing your uterine lining and potentially causing a uterine cancer. So progesterone.
Mhm.
I typically prescribe, micronized progesterone. It's as, quote, bioidentical as you can get, body identical. You can get it at CVS, Walgreens, 100 milligrams at bedtime. Do you use other forms of progesterone? Do you like the IUD for people who are perimenopausal? Can we talk about that?
Yeah. So, progesterone is optional. It's mandatory if you have a uterus. So
Mandatory.
we need something to protect the uterine lining. So our options are put progesterone in the uterus in the form of an IUD. That'll do it. Also, if she's having crazy bleeding, heavy bleeding, it will cut down or even stop her periods and give her contraception. So it's like, again, nuance. What are we treating? What does she need? Does she need contraception? What's my best? And she's having heavy irregular periods, and her ultrasound is negative, and we've ruled out polyps and everything. IUD is a fabulous option for her. It lasts 8 years, you know. However, okay, she doesn't have a uterus, but she's still struggling with sleep, with nighttime anxiety, restless legs. Progesterone converts to allopregnanolone, which binds to GABA in the brain and gives you that little bit of a sedative effect. So it is an option if you don't need it for endometrial protection.
So that's something that gets lost sometimes. I had a patient this week,
Mhm.
maybe it was last week. It's only Tuesday. I think it was last week, who has an IUD that's like 6 years old and is
Yeah.
menopausal. So she's on the estrogen patch from her gynecologist, but her gynecologist said, um, don't take oral progesterone because you have the IUD. And I said, but her sleep is terrible. I said, you can take oral progesterone in addition to the IUD, right?
Yeah.
You treat the patient,
Right.
not the right. You
Like,
treat
and
the
this is not synthetic progesterone. This is not the old Provera that was
right.
in the WHI study. This is bioidentical progesterone, and the body responds great to it. Now, some people don't do well with progesterone. They either have um, my words, my verbal memory sometimes in menopause is a little bit of a struggle.
I mean,
Um,
make it a
they
double
have
here.
a paradoxical effect where they're hyped up when they take it. Okay. Oral, we can try vaginally. We can put the same progesterone we take orally. You can actually put it in the vagina, lay down, and go to bed, but you will absorb it. And for some patient that works really well. Some people just feel hungover the next day, from the progesterone. It's too sedating. They don't feel right. It can sometimes exacerbate some mental health problems. So we have the synthetic progestins, like the combi patch, are great for those patients. Switching them to an IUD, taking them away from all the progesterone. And then there's Duovi. So Duovi has a conjugated equine estrogen. So the old Premarin is 0.45. So there's only one strain, combined with a basidoxifene, which is a SERM, selective estrogen
Receptor modulator.
receptor modulator, that basically binds, blocks, and downregulates the estrogen receptors in the breast and in the uterus. So I have patients who are persistently vaginal bleeding on HRT. Basidoxifene works great. They're studying it in DCIS patients right now, and that just hit, the I forget the conference, but it was presented at the conference, set the world on fire, and so any of my patients who are coming in with a strong family history of breast cancer and they're really, really nervous, we talk about this study, we talk about, how the mechanism of action of basidoxifene, and it's a really good option for them. So, we have nuance, not a one size fits all.
Right. Let's talk about, I love it, Mary Claire. And as you're talking, and as I think people are listening, it's so clear um, how complex and how nuanced the treatment of women is, which makes sense because we're complicated and we're more, we're better off for it. But we treat the patient, not, the numbers in the labs. We treat the symptoms that are sometimes invisible. Not everything is measurable in women's health. And you and I, among other doctors, did not learn this in medical school and residency. So it's really important when you're wondering what kind of care you need that you have a provider who is educated on the latest guidelines, understands the evidence, and understands the limitations of their knowledge. Like,
Hmm.
I think, I'm a good doctor. I don't know everything, but I like to
Yeah.
think that I say, look, I don't know the answer to this question. Let me send you to somebody who does. So I
And
think it's important people
I was a
ask.
terrible menopause doctor, and
Yeah.
I follow guidelines. And so, but I was taught that women tend to somaticize emotional, somaticize psychological symptoms, and that, it's always a little bit in her head. And, women just tend to get a little emotional at this age. When a woman came in her 40s with not sleeping well, weight gain, libido issues, headaches, increasing depression, some anxiety, it's a little bit crazy.
Yeah. I mean,
That
that was
it
the
was
memo.
psychology and not biology, and we don't do
Right.
that to men. We don't do it to men.
No, it's biological. It is biological. Let's talk about testosterone. We talked about estrogen, we talked about progesterone, and now let's talk about testosterone. Testosterone, I learned this last week. Testosterone levels start to fall in a woman's body at the age of 30. Like, I did not know that.
Yeah, so we have max levels, kind of like creatine and all kind of. They don't fall off a cliff like they do with menopause, right? It is an age-related decline, just like men, just like men. So we have a couple of places we make testosterone, and one will kind of take over for the other. But age-related decline doesn't fall off a cliff with menopause. By the time you're 50, you are at about 50% of the levels that you had at your peak at about 30. So, and testosterone receptors are all over the body as well, bones, muscles, brain. And so when we get these testosterone levels back, it'll say normal for your age, which is true. Normal means common. Normal means what most women will run, but it is not your 30-year-old level when you were peak performance. So so testosterone is a human hormone. Multiple studies, multiple medical societies are all in for the treatment of low libido that is causing distress for women with testosterone. Unfortunately, the Food and Drug Administration has not gotten around to approving a product for women in the US, so we have to borrow the men's.
Right. Right. We need to get the black box warning off of vaginal estrogen, and we need to get testosterone
So,
for women
yeah,
FDA approved.
testosterone for women. And we need to readjust the warning label on systemic estrogen. It's ridiculous.
It
It's
is ridiculous.
ridiculous.
I mean, it's just outdated. It's a bad look, FDA. It's a bad look if you're listening.
And look, it's not just this administration. And this
Oh no, it's
administration
not just it's
actually, there's a roundtable going on in a couple of weeks where they're trying to get these things done, invited by the new head of the FDA. So I don't want to get political here, but no administration has done well for women. So
100%. And actually, Marty Makari is on board with who the current FDA, who I know from Hopkins, is on board with women's reproductive health and women's menopausal health care. But like,
mm,
show us what you got, Marty.
yeah. So I think
So
they're working on it.
I think so.
Some of my friends are going to attend. So
Great.
pretty
I mean,
exciting to see what comes out of that.
it's great. It's great. Okay, so testosterone. So is there a reason that a woman shouldn't be on testosterone or try it for libido, for muscle tone, muscle strength, for metabolic
It's,
efficiency?
the studies are clear for low libido. The studies we don't have, Susan Davis would like come and chop my head off. She's the goddess, who wrote all those studies. I don't really think she likes women that much, but she's a good researcher. So, there is not enough evidence to clearly say that it will improve your muscle strength, bone strength when taken exogenously. But here's what we know. Women who naturally have higher testosterone levels for whatever reason, okay, they got lucky, have lower frailty scores, have lower osteoporosis, have lower sarcopenia, right? Their their bones and muscles are stronger.
Yeah.
So we know it's great for libido. No one who knows what they're doing is gonna argue with you for that. Okay. We just have to get some workarounds to get it prescribed, but we get it. Um, I tell my patients this data, especially if they have early osteopenia, osteoporosis, and they're doing the work. They're eating the protein, they're doing the resistance training. Adding a touch of testosterone to get you back up to a 30-year-old level may be helpful here. I can't tell you for sure, but it's not going to be harmful. So I started it for that reason. Now, Casperson and that group, they really think it helps with brain fog and cognitive abilities and stuff. I'm not there yet. But um so me being naturally skinny and having low muscle mass, because I have a body scanner and I measure muscle mass and visceral fat, I was like, okay, my biggest risk, if I run the cancer gauntlet, because I've lost two brothers to cancer and multiple aunts and uncles, if I make it through that, my biggest risk is going to be osteoporosis and frailty. And I'm going all in. I've got HRT on board. I'm at a therapeutic level. I've got, resistance training. I've changed my diet, whole foods, protein, plants. And let me add a little testosterone and see, it's not going to hurt me. Well, I did not qualify for HSTD. hypoactive sexual desire disorder. Like I give the questionnaire every day to my patients. I didn't qualify. Okay. There definitely was an uptick in the area. Nothing crazy, but I think I would miss it if it was gone. And, and I'm working out like a fiend. So, all good. And my bones look great on bone down Dexa. And, I'm still skinny, but with muscle, but it's not going away. And I'm building a little.
I see you with your weighted vest, Mary Claire
I'm
Haver.
trying.
I see you with your resistance training bands, practicing what you preach. It's great. It's great. So I think we can agree that obviously we want to follow evidence-based medicine, right? Like we don't want to go rogue. At the same time, the practice of medicine has always been about treating the patient and giving the patient information about what we know and what we don't know, right? And you can't always have a randomized controlled trial to prove causality, right?
Well,
We have to use
here's
observational data to in many ways, but first do no harm, of course.
here's where I'm so happy to be practicing medicine in the US, and we are not perfect. This is not a perfect system. As a physician, watching my counterparts in certain countries, across the pond, sometimes in South America, especially where they have socialized medicine, they are protocol bound.
Oh, bound.
And if you step outside the protocol, you will lose your license.
Yep.
I don't lose my license unless I commit malpractice where I harm a patient, But if I have a well-documented reason for going above a certain level or doubling up on something or using something off-label, which we do all the time, they are under threat to lose their license.
Right.
And I'm like, it's a good day to be practicing medicine in the US because
Yeah,
this is menopause and it's a little bit of the Wild West, and we're figuring this out as we go, especially in perimenopause. So
I have a patient who comes from Denmark and she has to hide her hormone therapy, her patches through customs because she's worried she's getting in trouble for taking hormone replacement therapy. She's like a 53-year-old healthy person. It's crazy. It's great.
And a lot of my followers across in different countries really struggle to find a menopause educated provider. I mean, same as here, but there it's depending on the guidelines of the country. And you know how long it takes for everybody in the room to agree on a guideline, 17 years to change practice.
Right.
So, it's pretty, the politics of this is crazy.
It is really crazy. Let's talk about blood levels. So patients ask me all the time, can you check my hormones? Right? They're either, the 47-year-old who's sleepless and irritable and maybe skipping a period here or there, and we have to check their hormones. And then you have the patient who's maybe 2 years post-menopause, no period for 2 years, and they want their hormones checked. How do you weave in the interpretation of labs or the existence of lab testing with your treatment of the patient?
Okay. So I'm going to flip my screen around and let's see if this works. I'm just going to pull up the normal hormone cycle of a woman. Let me see if I can do this.
Oh, great. Let's make a little, this is just, I love this. I feel like I'm in
This is a
class.
premenopausal healthy woman. Okay. And it just depends on what cycle day you are. And
that's a 28-day cycle. So that's that's 1 month.
This is a average 28-day cycle. Okay. And there's no flat line. There's no, there's a base, there's some peaks having to do with ovulation. Progesterone kind of just chills out until we get to ovulation, and then we see a spike. Estrogen kind of has 2 bumps. Testosterone has a little bit of a spike, probably to increase our libido, so we get pregnant at ovulation. There's always reasons for this. And then when we get to perimenopause, we lose the cyclical nature of this. If you've ever seen me do the zone of chaos, let me see if I can pull up I
don't know, but that sounds like a great name for a band.
So, okay. So let me play this for your followers. This is from what we did for Oprah. It's pretty cool. And it's so worth your... Okay.
How many eggs does a woman have?
We have 1 to 2 million eggs.
Oh my God, this is so great.
By the time we're 30, we're down to about 10% of that egg supply. And by the time we're 40, we're down to about 3% of the original egg supply. We lose those eggs through the process of ovulation. About 10,000 eggs die to get 1 egg to ovulate each month, and also we lose from the aging process as well. In a healthy premenopausal woman, the menstrual cycle follows a predictable pattern driven by 4 key hormones: estrogen and progesterone from the ovaries, and LH and FSH from the brain. The hypothalamus detects low estrogen levels and signals the pituitary gland to release LH and FSH. These hormones stimulate the ovaries to produce estrogen and progesterone. This cycle is repeated month after month until we reach perimenopause. What happens in perimenopause is we reach a critical low level of egg supply, where signals from the brain no longer work. There just aren't enough eggs to respond to those signals. What used to look like this every month for 6 months now kind of looks haphazard. Because the ovaries can't respond, the brain keeps sending more and higher signals to the ovaries to force the ovulation. Ovulations are delayed, the progesterone levels never quite reach where they used to be, and the estrogen levels fluctuate wildly. That is why we call perimenopause the zone of chaos. So that's the best
That's about right. Very clear. That's genius. Is that you talking?
I did it for when we did the Oprah Menopause special, and I worked with an animator, and it was pretty cool. And so I just pull that out whenever I'm trying to explain this, and it just
That says everything
people
you
are
need to
like,
know. This is why checking your hormones is a kind of a fool's errand because
it's crazy. So I get the want to do it. Now, when you're postmenopausal, all of that flatlines, right? LH and FSH stay elevated, estradiol and progesterone stay bottomed out. So we can easily diagnose postmenopause with a blood test, but usually if you hadn't had a period for a year and you used to have regular ones, that's menopause, and you're over the age of 45, that's menopause too. But in perimenopause, there is not a one-time blood, urine, or saliva test that is going to make that diagnosis.
this is why I'm
save
so
your
glad.
money, no Dutch test. There, please save your money. Find a menopause educated provider who knows what they're doing. If you listen to the patient, if you believe her, if you recognize the multiple organ system effects of the chaos of estrogen in your body, you're in perimenopause. And it's a 7 to 10 year process until the ovaries burn out and you've got no eggs left. So I make the diagnosis clinically. I am checking once we start treating the patients, especially in postmenopause, I'm checking to see for absorption rates. We're always checking testosterone levels because of very variable absorption amongst patients. We want to make sure we're not overshooting or undershooting. And again, nuance, follow-up, care.
I'm so glad you're writing a book about perimenopause because the zone of chaos, again, I think would be a great name for a band. It also would be a great name for your book, The Zone of Chaos. I mean, that's how my brain felt during perimenopause. I thought I was losing my mind, and maybe I was in other ways, but it was definitely the progesterone, estrogen, chaotic time, right? So you're right. It's a clinical diagnosis. What do you So then how do you tell during perimenopause? Let's say you have a 47-year-old woman who's in perimenopause, has the classic hot flashes, night sweats, irregular periods, but is still menstruating.
Yeah.
How do you decide if she's going to get pregnant or not? Whether to put her on HRT versus the birth control?
So, the biggest differences, there's two main differences between contraceptive hormones and menopausal hormones, okay? One is dose. Contraceptive hormones were developed to stop ovulation, to give your body enough estrogen and progesterone to block the hypothalamus. And the hypothalamus is tricked into like everything is cool and it stops sending those signals so you don't ovulate, so you don't have a baby, okay? The menopause hormone therapy is a microdose compared to that. It is a fraction of the dose. Formulations are very different. Most contraceptive hormones have ethinyl estradiol, 300 times more potent than your body's natural estradiol. It binds to that receptor and will not let go. Estrogen kind of binds and pops off, and you got more estrogen in the body, and da da da. So, ethinyl estradiol is cheap. We know lots about it. It's very, very safe. But to assume it acts the same as estradiol in your body to treat menopause, I think is a mistake. Now, if you need contraception, if you need your periods to be controlled, again, for the periods, we could do an IUD with some estradiol. We could do a birth control pill, okay? Most of my perimenopause was inadvertently treated with continuous birth control pills because I had polycystic ovarian syndrome and it worked great for me, okay? I got off the pill to see where I was, and I was immediately menopausal. But it took me 6 months to figure it out in my own body. So there you go, as the expert. So again, if she's doesn't have a uterus, has an IUD, husband had a vasectomy, she's monogamous, we don't need contraception, her periods aren't crazy, we may start talking about progesterone plus or minus estrogen. Just depends on where she's at. Again, not a one size fits all. Really depends on where she's at and what her goals are.
Yeah, and I think that's so helpful. I think one of the mistakes we make, if we're following pure guidelines, is to treat the calendar, not the patient. In other words, people, the definition of menopause is having gone a full calendar year without a menstrual period.
It's
It
so
doesn't
random.
right. It doesn't mean you can't at 9 months. If you're miserable, it's not like you have to wait it out.
What if you have an IUD? What if it's a leap year? Do you go 366 days?
What if it's a leap year?
Stupidest, most disservice to women's health. This crazy definition. It is ovarian failure. The end. That is what menopause is. Let's call it what it is. Our ovaries age twice as fast as any other organ in our body. It's, we're kind of a unique species. There's only a handful of mammals that do this, and there's not even, when we look at studies that have been done and why we have this gender health gap and why it's such a big glaring gap at the end of our lives, we don't have a mouse menopause. Mice don't go through menopause.
I hadn't ever thought of that, but that is absolutely true.
Now they have estrus, they have cycles, and they're difficult to study because guess what? Natural hormone fluctuations affect how medications work. So they just study male mice, and you can't have a perimenopause model in a mouse because to make a menopause model in a mouse, they take out the ovaries or they give them something that blocks the ovaries. There's not the transitional phase. We are owed centuries of research. Centuries.
Yeah.
So.
Amen, Mary Claire Haber. If you had one piece of advice I want to ask you two questions, okay? And then I'm going to let you go. If you had one piece of advice for a woman who's perimenopausal and going to her doctor to kind of advocate for herself, having listened to you, having read your book, what do you tell her to say to her doctor who may or may not understand menopause the way you do?
It's not your doctor's fault. They weren't educated. And most of us, I had no time in my 30s when I was trying to stay married and build a family and do all the things to go and learn on my own about menopause care. I didn't know what I didn't know. Okay. But so it may not be reasonable for you to be the one to try to educate your clinician, but it's okay to ask. So I would say download the Menopause Society guidelines, educate them. You're talking
about the 2022 North American Menopause Society expert guidelines. Mm-hmm. Print it out and bring it. Great.
And bring it. And maybe they won't help you, but maybe they'll help someone down the road. It's, I have a whole script in the book on,
buy Mary Claire's book, everybody. Buy Mary Claire's book, The New Menopause. It is
I have
amazing.
If your doctor says this, say this. And it's really just thought-provoking and it's not trying to be an asshole. It is really just just to give, and you remember, your well woman exam is not the time for you to address menopause. That is a screening exam for breast and uterine and cervical cancer and some blood work. And so you must make a problem visit and it probably will take 3 or 4. Okay. Now in my clinic, I don't accept insurance. So mine is cash pay. My patients get an hour. Now in the old model where I practiced before, they would have had to come for 4 visits in order for me to accomplish all of the things that I am able to do in one visit.
And then this is great. I love it. The last question, I think it's the last question, is what do you say to my patients and all the women out there who didn't get offered HRT, who are in their 60s, 70s, and beyond, who are feeling like they missed the boat? And mm-hmm. They may be sad, they may be depressed, they may be angry, they may be
angry. The boomers
pissed off.
Angry.
I don't blame any of my patients. I still give them vaginal estrogen. We treat their osteoporosis with all the lifestyle and all the things you talked about already. But I have a lot of sadness and empathy for women who didn't have this moment when they were going through menopause. What do you say to them?
It's never too late to be healthier. And if time has taken the opportunity of estrogen away from you for your heart health, your brain health, time, it will always protect your bones actually. But, we're not going to let this happen again to the next generation. So I can reassure them I'm doing everything in my power to empower as many women. And that is my next book. Now that the manuscript is in for the new perimenopause, I'm writing a book for, life after period's end. And so, once the hot flashes are gone and all that, how do we build better bodies starting at 60, starting at 70, And so I'll be 60 in a couple of years and I'm like Project 60. right? Like I'm going to build the bionic body the most bionic body that Mary Claire can have so that I can stay active, joyful, vibrant, and accomplish all of my goals in my 60s. And then I'm going to reset it for 70, and I'm just
I
going to
love it.
build on these habits,
I love it. I mean, as you talk about, as I talk about, health as a process, it's not an outcome. It's not a set of metrics. HRT is just a tool and toolkit.
Mhm.
And I do believe exactly what you're saying, which is that it's never too late to learn more about yourself, to learn more about evidence in the medical sphere, and to be healthier mentally, physically, hormonally, metabolically. Mary Claire, thank you so much for joining me. I know you have a very busy schedule. You got Oprah on the phone, you've got Brene Brown on the phone. Like, I'm just happy to have a little sliver of your time. And thank you for educating me, for educating my listeners, and for being such an advocate for women and women's health, and with also a real, an authentic humility that is unusual, I think, unfortunately, in people who have reached the level that you have. I think that humility is really, really important in leaders. Acknowledging that you don't know everything, acknowledging the limitations of what
Still
medicine can
learning.
offer people, and that you're still learning. And I think, as long as doctors can remain humble about what we know, what we don't know, and just try to help as many people as we can,
Mm.
and take care of ourselves the way we try to take care of our patients.
Yeah.
And it strikes me that you do all of those things and you do them well. So thank you for being here, and thank you for what you do.
Okay. Take care.
Bye.